a young person dislocates the shoulder, their tissues are still elastic. They'll dislocate the shoulder. They don't get a rotator cuff tear. But now I started finally understanding why is it that maybe after age 40, then when you dislocate your shoulder, you can get a rotator cuff tear. And actually, for people who are not metabolically healthy, they don't need to have a shoulder dislocation to tear the rotator cuff. It could just be a little sudden eccentric contraction of the muscles, and boom, they get their tear. And so I started realizing it's like almost everything we see is related to metabolic health. And so it just really started opening my eyes. And that's where I'm at right now. It's trying to create a bridge between the orthopedic field and the field of, the health community or the field of metabolic health, to trying to connect the two in what I do in my practice.
Okay, good morning, everybody. And we have Dr. Moreyra, and I'm sure I'm mispronouncing it, Carlos. Apologize. How are you today?
I'm doing well. How about you?
Well, I just got out of another podcast just a second ago, so I'm well warmed up. So let me ask you. So first of all, how do you pronounce your last name? Because I was trying to figure out how to do it. I know it's got an accent, which I can't roll my R's, but how do you say that?
Oh, Moreyra.
Moreyra.
So it's the last name comes from Galicia, up northwest Spain, although very close to Portugal. So sometimes people might think I'm Portuguese.
Got it. Okay. Yeah, I figured I couldn't roll my R's anyway. But first of all, well, welcome and thank you for doing this. Now you do orthopedics, so it's a kindred spirit here. It's good to see another orthopedic surgeon that understands that nutrition plays a role. And are you in Miami right now? Is that what I'm seeing with your shirt? Where are you at?
No, I'm in a small town called Rosemary Beach outside of Panama City, Florida. So I'm in the Panhandle.
Okay.
Now I grew up in Miami, and I would consider Miami to be, my hometown.
Okay. Well, nice. I'm going to go there. I think I'm going there in November. So, well, tell us a little bit about yourself. I know you're in orthopedics, and tell us a little about your background, if you don't mind.
Yeah, no problem. So I'm Carlos Moreyra. Like you said, I'm an orthopedic surgeon. I went to medical school in Temple University School of Medicine, and I graduated from there in 1997 after I got my bachelor's at Florida International University in Miami. I went to medical school with the Health Professional Scholarship Program with the Navy, so they paid for medical school, so I had to pay them back. I did a surgery internship in Naval Medical Center in Portsmouth, Virginia. And after that, then I went to flight surgery school here in Florida, Pensacola, and became a flight surgeon. So a flight surgeon, it's a primary care doctor for pilots and air crew and air traffic controllers. We're not doing surgery when we fly. So I did that for a few years. Then I got out. I did some orthopedic research in the civilian side. I joined the reserves for that. And then I went back to Temple University Hospital for my orthopedic residency after a 7-year gap. After that, I did a sports medicine fellowship at the University of Illinois in Chicago. And I went back to active duty. I already had paid my active duty time, but I decided, I want to go back in. I don't think I want to be the civilian side, or at least not yet. So I was an orthopedic surgeon working in Naval Hospital, Pensacola, and I was there for 4 years. During my third year, I deployed to Afghanistan, and I was in Kandahar for about 7 months. Then after I finished 4 years, I decided, I'll get out, go back to the reserves. And I was in Miami at a full-time practice, employed. Left that job for various reasons. Then after that, I was doing some travel work. And then I got a full-time job in the Florida Panhandle, actually not about an hour and a half from where I live here. And that was when the pandemic hit. Numbers went down. The CEO was not happy. We were losing money. So I left. It was nothing to do with patient care, but, people didn't want to come to the orthopedic surgeon, and people were staying home. So, people are not getting injuries, less number of fractures, that kind of thing. And so now I've been doing travel medicine again, currently working in West Virginia by Lewisburg, which is kind of close to Virginia. But then I come here every other week. So that's what I do now. And then how I got interested in metabolic health. Well, one of my classmates, who's really one of my best friends, is Dr. Shawn Moreyra. He's been on your podcast before. I think it was around maybe 2019. And he so maybe he was following all the. So, and it was actually through interactions with some patients that he started really discovering about, paleo, ketogenic diet, and then years later developing to the carnivore diet. And so he was able to kind of fix some of his own health issues. And then he started a practice of health optimization with a partner. And it was by doing CAT scans, not CAT scans, sorry, MRIs, some patients, he was able to track visceral fat, and he kind of realized, visceral fat might be just to be the best marker that we can follow for health. And so that's what he started doing with his practice. And the reason I mentioned him is because he then showed me and sent me emails and pictures of some of his patients, and one that I would consider the most important picture that I've ever seen for my personal medical education was that of an MRI. And I don't know if you can see it well here.
Yeah, it's
showing an occlusion of the left middle cerebral artery. And actually, it's hard to see here, but there's a lot of purple here in the carotids and the base of the artery, which shows some partial occlusions. And then through dietary intervention, the left middle cerebral artery open completely. But not only that, even if somebody would say, well, that could have been an embolus that just resolved. No, but if you look at the carotid arteries and basilar arteries, there was some partial occlusions here that completely open, well, not completely, but mostly opened up with just dietary interventions. And that really just surprised me, because I thought, I'm like, wait a second, there's no statin that can do that. At least not that I'm aware of, but there's no medication that does that. So for me, the paradigm of health just started shifting. I went to medical school thinking, well, high blood pressure, type 2 diabetes, it's one of those things that you get when you get older. But if you have mild symptoms or a mild case of high blood pressure, diabetes, then you can do some dietary changes, following guidelines. Little bit we know. But if it's really severe, then you have to have medications. But with this, then the paradigm just started shifting. It's like, no, we don't, diet and lifestyle is not just to treat like a mild case of type 2 diabetes or a mild case of essential hypertension. It's actually the cure. A poor diet is the reason why people are getting this. So, idiopathic or essential hypertension should probably be called, insulin resistance hypertension or by a similar name. And so my thinking started just shifting about this. And so I started applying some changes to myself, and, definitely saw improvements in my diet. I didn't really start doing this very seriously until maybe like 2019, shortly before the pandemic. And then also started realizing, it is the reason why patients go in to see an orthopedic surgeon. Now, of course, you have the athletes, maybe fracture an ankle, something that tear an ACL, and that happens with athletics. But rotator cuff tears, arthritis, all these things are actually really preventable. And I started exploring about and thinking more about, advanced glycation in products, which is when, molecules of protein get peppered with glucose or what have you, and they lose elasticity, they become more brittle. And I realized, oh yeah, this is the reason why rotator cuff tears are just so common in the elderly population or middle age. A young person dislocates the shoulder, their tissues are still elastic. They'll dislocate the shoulder. They don't get a rotator cuff tear. But now I started finally understanding why is it that maybe after age 40, then when you dislocate your shoulder, you can get a rotator cuff tear. And actually, for people who are not metabolically healthy, they don't need to have a shoulder dislocation to tear their rotator cuff. It could just be a little sudden eccentric contraction of the muscles, and boom, they get their tear. And so I started realizing it's like almost everything we see is related to metabolic health. And so it just really started opening my eyes. And that's where I'm at right now. It's trying to create a bridge between the orthopedic field and the field of, the health community, or the field of metabolic health, to trying to connect the two in what I do in my practice.
Yeah, that and your background is not that dissimilar from mine. I had a military background. I didn't go through an HBSB scholarship, but I went through I had a scholarship to medical school as well, and then I didn't do flight surgery. So you had this experience in this primary care field. Most people don't know that flight surgeons are primary care physicians. But um, when were you in Kandahar again? What was the year?
I was in Kandahar from actually December 26, 2012 to, I think, August 4th of 2013.
Okay.
So, we had a white Christmas in Kyrgyzstan, actually. That was our last stop before arriving to Kandahar.
Yeah, I remember flying through Kyrgyzstan as well. I was in Bagram 2007 for the first half of 2007. Was Kandahar a pretty busy experience for you? Were you guys pretty inundated with trauma, or how was that?
Not as busy as you were. I've seen some of your videos where you discuss how many patients you had. We have traumas get called in every 3 days, and so usually maybe anywhere between 1 to 4 patients will arrive.
Yeah.
We have the beepers, and we'll just start doing the 20-minute hike to the hospital. But on the average, I would say that these patients will arrive around every 3 days. And we saw everything. We saw U.S. soldiers and
NATO,
allies or other members of NATO. We saw the enemy. We saw civilian. We saw children from local communities. But it was not as.
I had a very similar experience in the fact that we took care of the enemy, the Taliban, the kiddos, the NATO, the Afghan forces, U.S. forces, on and on and on. So it was quite an interesting experience for sure. Do you you'd mentioned rotator cuff pathology? We've long known as orthopedic surgeons, diabetics get higher incidence of rotator cuffs, but we kind of just, I didn't really think, again, not having a primary care background, we didn't really think much about some of those things, as far as, when you're taught about orthopedics, it's kind of just, here's how you do the surgery. These are the indications. We didn't really, outside of, is this person like a frail old person that has, no ability to heal, but it's much deeper than that. We don't get trained that. Did you find that your orthopedic surgeon prepared you to counsel people on diets?
Honestly, not really. Although I would say one section. I did have my mentor in residency was Dr. John Kelly. He's a shoulder surgeon currently now at the University of Pennsylvania, and he's much into health. And he had instructions or nutraceuticals that he'll give to his patients. And I got a copy of that, but that was his instructions were more like based on eating a plant-based diet with lots of fruits and vegetables with all the antioxidants. But that was about the only exposure that I had. The books, it doesn't really talk about that. You learn about advanced glycation end products, but they don't really kind of make the bridge between this is why that it's important to and how it correlates to the patients that you take care of. And it wasn't until one day I was in Miami, I was in my parents' house, and a personal trainer who works with my parents, his name is Camilo, he's Cuban. And he just mentioned, yes, that with age, your soft tissue elasticity, which I kind of knew that. But when he said that, I started thinking, wait a second, that just explains everything. As you learned, well, if you're young, you dislocate your shoulder, you just tear your labrum, but you don't tear your rotator cuff muscles. But once you are 40 or older, when you dislocate something, tissues are less elastic, more brittle, and things start changing. And that's what clicked in my brain. And I was actually doing my fellowship, or I had just finished my fellowship when I had that interaction with it. And that kind of just led me to that rabbit hole. So I do feel like, no, we're not really trained. Nobody really talks about advanced glycation end products and tissue being brittle and oxidative stress and all this other stuff, as being a reason why people have rotator cuff tears easily. So I kind of had to learn that on my own. And at this point, I almost feel like I read the nutrition literature more often than I read the orthopedic literature, to be honest with you.
It's interesting. I know whenever you stick a scope in like a 15-year-old kid's knee, I mean, it looks beautiful. It's white, it's pristine. There's the cartilage looks beautiful, the menisci are beautiful. And you stick it in a 50-year-old and it's all brown and dark yellow. And it's, I just think that's a Maillard reaction. I mean, I think it's just this chronic glycation of these tissues and they become friable and they're so easily torn. Can you see that? I mean, I know you've probably scoped younger versus older and seen that difference.
No, you can definitely tell the difference, and whether the knee or the shoulder. And I think the shoulder actually, probably more so because you're getting more of a view of the rotator cuff. So, I mean, I did an ACL reconstruction actually in a 15-year-old about 2 weeks ago, and other than the fact that she had an ACL tear, and a meniscal tear, was a bucket hand that was displaced, so I had to fix that. But the quality of tissue is actually pretty good. But you do a rotator cuff repair, and sometimes you look in there and you will wonder, is this even going to heal? Like, you just suturing tissue that is just unhealthy. And a caveat to that, now in orthopedics, I always talk about the biology, that we got to address the biology. So, whether it be the crimson duvet for like the rotator cuff, where you make little holes to try to get some of that bone marrow to bleed right where you make the repair, or whether people are injecting platelet-rich plasma in the shoulder, is still kind of like this unhealthy biology that you're trying to help you heal the tissue, when in reality, you gotta change the entire nutritional environment. But that's harder to do. But not only is it harder to do, I don't think we're really even talking to patients about it. I follow orthopedic surgeons on Twitter, not as much as nutritional people, but I do follow quite a few. And I'm still amazed at how many pictures and x-rays and MRIs and things like that they put in there. And you can tell the discussion of nutrition is just lacking. So-and-so BMI of 50, trying to lose weight loss. Well, how are they trying to lose weight loss? How are they trying to achieve that? Is it with standard recommendations, or are they going on a low carbohydrate or a carnivore diet? There's no discussion about that. And so it's almost like they're doomed to failure, because if they're trying to lose weight by using some old paradigm that doesn't really work or isn't successful, then it's not going to achieve. It's not going to be able to achieve what they're trying to achieve. And I find that there's a lot of lack of information in orthopedics when it comes to that. And I'm basically trying to wear two hats here. The orthopedic surgeon and the metabolic health person, and trying to kind of bridge the gap. I feel like I'm making maybe a little progress, but it's very slow.
Yeah, I think that, I just, when I was, one of the reasons I chose orthopedics was you don't have to deal with all the chronic disease and the primary care stuff where no one takes their medications and you just blame the patients. And at least with orthopedics, somebody breaks their femur, you stick a rod down it and you're done. It's like, I fix you. But the reality is, like you mentioned, you're just taking care of chronic disease that presents in a different fashion, because, like you said, most of the arthritis, the peripheral neuropathies, the tendinopathies, all this stuff, even some of the fractures probably are preventable. Like I said, the fragility fractures, it's just, absolutely, a lot of it's due to a bad diet. We're seeing, and I think, I don't, thinking about when I first started into the field compared to now, I mean, even the number of kids that are developing, they're tearing these things that they probably wouldn't have torn had they had a better diet. I think the tissue quality, if you've got poor tissue quality, you're more likely to tear things. I mean, that's pretty clear to me. And, we're just kind of putting it, well, kids are getting more ACL tears these days because they're more active or something, or they're more sports, but really kids are less active, if anything, compared to where they were, 20, 30, 40 years ago. And yet we're seeing a higher incidence of these pediatric ACL tears, which I remember at the beginning, it was like super rare. You have to send them to a specialist. And now it's like, well, a certain percentage of your practice is, pediatric kids, 10, 12-year-olds tearing their ACLs, which is kind of crazy in my view. So you're doing locums work, which is, I guess it's tougher to have a meaningful long-term relationship with a lot of patients, and some, depending on how often you move. But because for those people who know, some doctors will go from hospital to hospital and they'll travel around. It's nice. It can be a nice lifestyle because you don't have to deal with some of the administrative BS. You're not like, you're just like, I'll go to another hospital. I don't need to deal with this stuff. But how are you able to bridge or broach the subject of nutrition with some of these locum patients, or do you even try?
No, I do. At least I do my best. Obviously you're limited by maybe 15 minutes appointments, that type of thing. It's really hard to address all these issues in a short appointment, but I do have a set of instructions that I give to patients. And, and I read through your book, CarnivoreDiet, and you talk about your staff and yourself cannot keep up with printing more forms to give out to patients and so forth. And I kind of feel like I'm at that stage. So I have a 1-page instruction on nutrition, 1 page on bone health, dealing with osteoporosis, kind of a supplement to that, 1 page for diabetes. And I tend to keep my instructions to 1 page because I want them to be able to read them. And, a lot of these patients, they go to the ER for something, they print instructions out of some database. Oh, you have a fracture of your ankle. And then they give this instructions to the patients. It's like 10 pages thick. Nobody reads through that. And it really doesn't may not even apply specifically to the diagnosis, So I try to do, single space instruction, just 1 page. And I ask the patients, just please read it. This is not off the internet. I wrote this myself. It took me 2 years to kind of polish it off and get it to where I think it's perfect at this point. So I did try to address these issues. I'm always trying to find something to talk about other than their weight, because, I'm not going to sell somebody, well, you weigh 250, 300 pounds. I try to find something else so that, they don't offend it or what have you, whether it's elevated triglycerides. In children, I tend to find kids with acanthosis nigricans on their elbows or on their knuckles. And I'll tell them, or I tell the parent, this could be a sign of diabetes later on in their life. This is like an early warning sign for diabetes. So I usually try to find something that we can talk about. And if it's somebody in their 50s, especially a woman in their 50s or 60s, it's really easy because after menopause, then, the bone density starts going downhill quickly. And so for me, it's an easy way to kind of discuss about nutrition. So I do it, and pretty much everybody with arthritis, anybody with any condition really that could be addressed through nutrition, which for my patient population, working right now in West Virginia, it's probably about, maybe 90% of my patients really.
Yeah, it was kind of funny. Initially I started out with, people that were clearly overweight or obese. And I would say, this is a 1-page handout. These are some videos you could watch. These are some books you can read, type of stuff. That's how I was doing it. And then after a period of time, I started to see that, like rotator cuffs, this probably has a relationship to nutrition, and carpal tunnel syndrome, these peripheral neuropathies probably have a role in nutrition, because I saw those getting better when we changed the diet. And then I was kind of funny, for a period of time, I was checking fasting insulins on people with different diagnoses because I was curious. I was like, well, I bet your fasting insulin's high, and you come in with carpal tunnel, and lo and behold, it'd be 15, 18, 20. It would be elevated. And I was like, well, I think there's a metabolic component here. And I know that and not everybody, as not everybody's going to take your advice and follow the diet. But when I was putting people on my OR schedule, particularly joint replacements, if I could get them to do the low carb diet or the ketogenic diet, they just seemed to do better. They just seemed to have less inflammation. They had less swelling. They had better range of motion. They were like, as some people, I don't know how many knee replacements you would do in your practice, but some of those people are pretty damn miserable and in pain. It's tough to get their pain under control. You're in there with the anti-inflammatories and the Toradol and the, Dilaudid and all that, and the nerve blocks and all this stuff. And they're still having pain. But these people that you put on these diets, a lot of time they're just sitting there chilling out. And you're like, are you sure you had a knee replacement yesterday? Because it was I thought I saw a big difference. And I don't know if you see something similar with your patients that do that.
I haven't had a knee replacement in some time, just because of my schedule of working at different hospitals. Although my current hospital hasn't been doing them because of the pandemic, but they're now finally opened up to that. So they're pretty sure that we'll be booking some soon. But I did have one particular patient that it was morbidly obese. I suffered a Jones fracture, and it was during the pandemic, and so I had all the time in the world. I mean, I had these like 1 hour appointments where I could just chit chat with a patient. I just told them, listen, man, where you have to leave, just leave, or just tell me to shut up and I'll shut up. But I could just talk about nutrition forever. And he was morbidly obese, Jones fracture. I looked at his hemoglobin A1C, and it was like 13.4. So I started talking to him about low carbohydrate diet and, emphasizing meats and eggs, and, forget about the old paradigm of like fruits and vegetables, blah, blah, blah. And 3 months later, he's like, yeah, I want you to order a hemoglobin A1C. I want to know where it is. And now the downside is that he was putting all this weight on this Jones fracture, and so it kind of went into non-union really. And I was about to leave that job, so I had to refer him to foot and ankle surgeon. But his hemoglobin A1C went from 13.4 to 8.7 in 3 months, which it's a drastic change. I mean, it's still diabetic. It's still a lot better, and it was a significant amount.
So anyway, just for you guys, just to clarify, because most of you guys have not heard the term Jones fracture before. So Jones fracture is a fracture of the base of the fifth metatarsal bone in the foot. So the little pinky toe, you go back to the metatarsals and kind of the midfoot, and that's at the base there. And those notoriously don't heal, and so sometimes those would be ones where you will often have to put a little screw in there. So patient lost weight, A1C improved, which is phenomenal, obviously. And probably his endocrinologist probably couldn't get him to improve his A1C. I had a patient who he needed, he basically big guy. He was like close to 400 pounds. He was bilateral shoulder, bilateral knees, all of them worn out, needed replacements in all of them. And I said, well, and this is how I got into diet in the first place, is because, we got to, as a community of orthopedic surgeons, we decided that, hey, we can't operate on people whose BMIs are over 35 anymore. It's just too high risk. Complication rates, blood clots, infection rates are higher than we want to talk. So we want to get everybody under BMI 35. And it was hard to do. I mean, you get people in there and they just won't lose weight. I mean, you tell them, and you'd say, hey, look, we got to get you down. You weigh 320. We need to get you down to 240. And it would never happen, and they would come back just crying. And if they're females, they'd be crying in your office about how much pain they're in. And you'd finally concede and just do the operation and say, weight loss unsuccessful, and you'd have to document that. But I did manage to put some people on ketogenic diets, and I had one fellow who was, like I said, he was close to 400, and he lost, darn near 100 pounds in about 6 months. And his primary care physician told him that it is not safe for him to lose so much weight. And he'd been seeing this guy for 20 years. I'm like, you've been seeing this guy for 20 years and you're 400 pounds. And now he tells you when you finally do lose weight, it's not safe. It just made me laugh. I thought it was just crazy. But that's what got me into having to get patients under a BMI 35 of applying diet, having to say, because it was like, well, if I can't operate on people, I can't do what I'm supposed to do as an orthopedic surgeon. So I got to figure out how to make these people lose weight. And so I started putting them on these low carb ketogenic diets initially. And that kind of put me down this rabbit hole and started me on my journey where I am. What do you think? We kind of touched on the fact about osteoporosis. How do you think nutrition, because when I learned about, or the fracture care, it's, give these people, 1,500 milligrams of calcium a day, or maybe a little vitamin D, but that was the extent of nutrition for fracture care. Do you think it goes beyond that, or prevention of osteoporosis?
Oh, absolutely. Absolutely. And I still see recommendations to just calcium, vitamin D, and then just leaving it at that. So for instance, let's just talk about calcium. So, I mean, some studies have shown that just supplementing calcium post-menopausal women, just all it does is increase the calcification of the arteries and soft tissues. Then the recommendations for vitamin D is just of like 600 or 800, units a day. That's just like really low. You have to go way higher than that. And it helps once you get higher too. It also helps with immunity, helps with cancer prevention. Now, whether that's a direct cause or just a simple association, and vitamin D is just a marker or as a proxy for good health, I mean, who knows? But there are some studies showing that higher supplementation of vitamin D does help. And not in the topic of osteoporosis, but I'll tell you this one though. For joint replacement, there was a study where they were doing joint replacements in rodents. I'm not sure how you do a rodent joint replacement, but I mean, I'll take the word for it. The study group received vitamin D, and they had a decreased rate of periprosthetic joint infection. So that was actually as a cause of the vitamin D, not just because these rodents were healthier and they had a higher vitamin D level. So some people, myself included here, if we're going to do a joint replacement, I'll tell them to load on vitamin D. And for that hip replacement that I was talking about earlier, I told him, yeah, we should just take like 20,000 units a day and do it for like 2 weeks, something like that, because I think his vitamin D levels were low. Then the vitamin K and the magnesium are the two other micronutrients that really need to come into the conversation. I think those are the key ones. I think particularly vitamin K2, not K1. We need to think about vitamin K as what really is vitamin K1. And if you look at hospital formularies, the only vitamin K they carry is K1, which really affects more of the blood clotting pathway and the vitamin K dependent factors, clotting factors like 2, 7, 9, and 10, protein C, protein S. But they don't really address vitamin K1 doesn't address so much like where do you send the calcium? And that's where vitamin K2 comes into play, which obviously it's found mainly in animal products. The only time where you might see it on like plant products might be like fermented, soybeans, natto, like Japanese like to eat that. But it's actually made by the bacteria that are fermenting the soybeans. But you can get it from liver, you can get it from like pastured eggs and so forth. And then magnesium plays a role too. And so, although I have not come across a study showing this, but I do tell my patients, if you're going to take calcium, or maybe you should take calcium, but you must do it with high levels of vitamin D, magnesium, and vitamin K2. Because if it's just going to be calcium by itself, no good. Then the other factor is, besides those micronutrients, is the issue of protein. Protein is not emphasized very well, but there are studies that have shown that if you do calcium vitamin D, it doesn't do anything for bone density. But if you add protein, then it does help the bone density, either to increase it or to prevent the loss of bone density. There was a researcher out of, I think, Creighton University in Nebraska who kind of wrote about this, and he's got his own blog and quoting the papers about this, about the importance of protein. And bone has, it's like 40% protein. The dry weight of bone is about 40% protein, mostly collagen type 1. And so it makes sense to be able to have an adequate supply of protein. It's not just putting calcium. I mean, you can't make a house with just by putting a bunch of cement powder and expecting a house to be built. No, you got to have all the right ingredients. And I think the same is true for bone.
Yeah, and we see the associations between folks on vegetarian, vegan diets, and recently I think there was a analysis looking at about a 43% increase in fracture rate, and I think that's probably has to do with the protein quality, quite honestly, and that's something even when you look to the orthopedic textbooks, they don't talk about protein like you just mentioned, and collagen, type 1 collagen, like you said, 40% of the bone, and we're not even addressing it. That's the skeleton of the skeleton, which all the hydroxyapatite and all the calcium and phosphorus is laid down upon. And I didn't know about that. I literally never knew about that my entire career as an orthopedic surgeon until I started looking into nutrition research, which is kind of mind-boggling if you think about it.
Yeah, absolutely. And talking about the books don't talk about it. Uh, I won't mention the names, but they are very well-known textbooks of orthopedics, and I've searched for words such as sarcopenia with zero results. And I have these books because I travel for work. I have this on my phone. I mean, I can look at the textbooks right on my phone. So I can search the word sarcopenia, no hits. I can search the word osteosarcopenia, no hits, not a single mention. Textbooks on general orthopedics, on textbooks on fracture. It's amazing. I think, for instance, sarcopenia has got to be the least talked about word that we should be talking about. And as you know, sarcopenia is basically the loss of muscle mass related with aging. Um, so it's time for us to really just change the paradigm. And I know you've been working on this for a while, much longer than I have, in terms of nutrition and metabolic health. But it's kind of disheartening to see that these terms are not being even described in the textbooks.
Yeah, I mean, everybody's aware of obesity and then sarcopenia, which is it's a complicated word that most people don't understand the meaning of because, unless you understand Latin, I guess you don't know that, but at least intuitively. And then we're seeing a sarcopenic obesity on top of that, which is, you've had those patients that are just
Mhm.
very obese and yet they have no muscle mass and their bone quality is horrible. I mean, it's like, I liken it to like, cornbread, you literally, you put a, you put a screw in there and
Yeah,
you're not like, did I even get any bone? It looks like it on X, but you don't, you get that tactical feel back that when you get a nice, a nice bite of bone and then you're like, you feel like you're screwing into like cornbread. I mean, it's crazy to see
it's
how,
true.
how bad that stuff is. And so have you, since, I mean, well, I mean, what is your perspective of things like I'm saying things like peripheral neuropathy have a neurologic component or sorry, nutritional component. Do you see that as well? I mean, the tendinopathies and things like that, is that something you see? Can you I mean, a lot of times you can look at someone and you can see what they look like and you're like, I know that their tissue is going to be bad. I mean, is that something you see?
No, I think no, absolutely. Pretty much every day. To me, the skin is a window to the bones, and they both use collagen. The teeth can be a window to the bones, a window to the bones too. Um, Patients with poor skin, just skin that is like very thin, like grandma kind of skin, that their bones not going to be very healthy. The moment you cut and like you go to the ankle, um, and like you were saying, it feels like kind of like just crumbs of bread. I have had to change the way I fix those fractures. I mean, it's one of those things that I kind of had to learn after residency, that my approach to reducing a fracture or fixing it is very different for patients who have osteopenic bone versus somebody who's young and healthy with like robust bone. You put a clamp around the fracture fibula, and that thing is going to crumble. Like I have to change the way I reduce these fractures. You can't put a lax screw on them because it just will crumble. But so I noticed a relationship between skin and bone, and there's literature to back that up. Particularly in postmenopausal women, where they say like the quality of the skin it's related to the bone. I also see it in terms of when we talk about tendinopathies and so forth. You know, carpal tunnel syndrome, if in diabetics, very common. Trigger finger, if they have multiple trigger fingers, almost always they're diabetic. Um, I think I've only had maybe one or two patients in my career where I think they have multiple trigger fingers and they were not.
So that echoes my experience with the carpal tunnel syndrome with the trigger fingers. If you guys don't know what trigger fingers, finger will get locked in position, and you got to literally like pull it open, and you go in there, and you can treatments often were injections in there, and then sometimes you just you do a little surgery, and you release this thing called the A1 pulley, which is a little band that comes across the flexor tendon in the hand. You just make that little incision and it opened it up, and that was a pretty common. So I used to do a bunch of those. Very common problem. And what about, it's interesting. I've actually had a couple people relate to me that their Dupuytren's contracture has actually improved with diet, which I think is pretty interesting. And, you guys probably, as not a hand surgeon, I mean, Dupuytren's is not something most of us want to deal with because it's such a kind of a pain, quite honestly. I don't know. Did you do Dupuytren's contracture releases? Is that something part of you normally do?
No, I don't do them. With the advent of collagenase, which you can inject it, I have considered doing that, but I have not done a single case of Dupuytren's. I do talk to the patients about it. And one interesting thing about Dupuytren's, is that when I was when I was writing a paper about adhesive capsulitis during my fellowship, there was a paper from HSS, Hospital for Special Surgery in New York, that described the pathology of adhesive capsulitis or frozen shoulder as similar to that of like Dupuytren's, and which is kind of interesting in terms of the inflammation that you see in the synovium or the joint capsule. And adhesive capsulitis, as you know, it's related to diabetes and other kind of endocrine disorders. And there are patients that get better with a ketogenic diet from their adhesive capsulitis and their frozen shoulders. So, there could be an association with that. And I guess that would explain why you have patients that would improve
Yeah,
on a ketogenic diet.
It's interesting. For you guys, Dupuytren's is kind of this kind of contracture of the hand, particularly around the pinky side off, and you get this scar banding in the palm, which is kind of wraps around the neurovascular bundle. So it's really challenging to take care of. But it's interesting because they use classically, it's like Scandinavian background and alcoholism tend to run with Dupuytren's, and you see the same thing with Lederhosen's disease and Peyronie's disease, which affect the sole of the feet and the penis. Actually, which is kind of a sort of sad thing to think about. But do you know, as far as, we talked about kind of fracture, situation, what would you recommend, like for someone, because we have a lot of females that participate, many of them are approaching this, or will be dealing with fracture risk as they get older. How do you prevent it? What are your thoughts on prevention?
Yeah, so basically I give them my instructions on health and osteoporosis reversal and prevention. And so basically it boils down to this, and this will be kind of a quick list for the audience who's like listening to this. Basically, lifestyle changes include quitting smoking or other nicotine or tobacco products, no more than 2 alcoholic beverages a day. And that's from association studies. That was not a randomized study though. Sleeping well, 7 to 8 hours, and to wake up naturally and to decrease stress. Increase weight-bearing activities such as walking and balancing, core strengthening. I recommend Tai Chi. And a lot of people like to do yoga, and yoga, I think it's okay, but I think Tai Chi is better for the cartilage than yoga, because in Tai Chi, you're constantly moving. In yoga, you're holding poses and you have like this cold adhesion of the cartilage. And I think once you try to start moving again, could potentially, at least my own theory, lead to like a tear of the cartilage. But in Tai Chi, you're constantly moving. So I think it's better. Posture training, strengthening exercises. A lot of people like to walk. It's like, well, I do weight-bearing exercises, I walk, but I don't think that walking is really enough. You kind of have to have more resistance training to help prevent osteoporosis besides walking. Increasing sunlight exposure in order to make endogenous vitamin D by just avoiding not burning. Then eliminating processed food, sugar, grains, and soft drinks that contains phosphoric acid. I think that was part of the Framingham osteoporosis studies, where they show an association of phosphoric acid sodas and osteoporosis.
Yeah, Carlos, let me interrupt you there for a second, because that, all these soda beverages have this phosphoric acid in there. We don't really think about that very much, but we might see that in other non-sugary drinks. Even sugar-free drinks might contain that. Is that correct? Is that fair to say?
Yeah. That's probably, I follow these things myself, probably with the exception of Diet Coke. I've looked at Diet Coke and it has phosphoric acid, which kind of makes me sad. So yes, you can be a diet soda and it can have phosphoric acid. So then the other things that I tell them is to limit caffeine to 2 a day for postmenopausal women, also from an association study. But caffeine is one of those like conflicting things, and there are people who love caffeine and they say not an issue. Some people say, no, you got to stop it altogether. So I'm not exactly sure where the truth lies in that one. Consuming fermented foods. There are two. We don't know much about the microbiome. The microbiome is very complicated, obviously, but at least I've been able to pick up 2 things, and that is Lactobacillus reuteri And Bacteroides bacteria can be helpful in osteoporosis. And so those are probably two things that we probably should be looking at when buying yogurt or kefir milk to see if it includes Bacteroides and Lactobacillus reuteri. Other things would be like consuming wild-caught canned sardines in salmon with the bones, because that becomes a good source of calcium. Full-fat dairy. I have here for prunes and cooked green leafy vegetables. I know that's not carnivore, but there have been some studies showing prunes are good for osteoporosis, but those were all funded by the prune industry. So
prune industry,
take it with a grain of salt. I know, and a new paper came out like last week, also sponsored by the prune industry. They're getting hard about that. And a protein-rich diet, beef, lamb, pork, chicken, etc., wild-caught fish, pastured eggs, shellfish, such as oysters, and then other protein sources such as bone. Then the supplements that might be helpful would be vitamin D3. I start off with like 5,000 units a day, and I think that's 5,000 units a day, somewhat or kind of like indefinitely, or at least long term. It's okay, probably for most people, but it's really important just to measure vitamin D level, or more precisely, a 25 hydroxy vitamin D level. My target recommendations are for 60 nanograms per milliliter. Then vitamin K2. There are supplements for MK7 or MK4, and those two have been shown to be helpful for osteoporosis. Obviously, if somebody's in coumadin, that's an issue, because coumadin, warfarin is a vitamin K antagonist. So we'll have to talk to their provider about that, if they can be switched to a different blood thinner. Vitamin C, vitamin E, magnesium. Magnesium, depending on the formulation, some of them can really just induce, very loose bowel movement. So I tend to recommend just glycemic chloride or L-threonate. There have been some other supplements like that have been shown to be good in osteoporosis. Red clover extract, Canomylis fructose, I'm not sure if I pronounced that correctly, and the virgin coconut oil, and then cornelian cherry pulp in diabetic patients. But these are like esoteric supplements. I think more important is just to focus on getting adequate protein, and I would recommend animal-based protein, really, and just getting a lot of sun, but without burning, and then vitamin D3, K2, and magnesium. And then the other things that I think are very helpful too is to actually consider those medications that they're taking that are bad towards osteoporosis. Okay, proton pump inhibitors, things like esomeprazole, which is Nexium. I mean, the PPIs are just terrible. They've been associated with autoimmune disorders. They're associated with osteoporosis. They change your microbiome. You're not making acid anymore, or markedly decreasing the amount of acid that you have in your stomach, and just changes the entire microbiome and the ability to absorb, calcium and other nutrients. So I think possibly the histamine 2 blockers like Pepcid, which is famotidine, they may be associated with that too, but at least the correlation is not as strong. And then in diabetic patients, medications such as like the glitazones, they could be associated with osteoporosis too. And obviously, steroids like prednisone can be associated too, big time. Although if they're in any kind of chronic dose for that, they really have to talk to their physician first, because those cannot be stopped cold turkey whatsoever. So my instructions are pretty clear to telling the patients, talk to your provider first before you start, decreasing or changing these medications. And so those are the main ones. And actually, one that I forgot to mention is like the antidepressants and some other psychotropics, the SSRIs. Those are also associated with osteoporosis, and they're so common. I mean, most of or I would say maybe at least half of the patients that I operate on for hip fractures is taking at least one of these medications. And so they're really kind of defeating themselves. They take it for whatever, because they have acid reflux disease because of their diet, and then they come in with a fracture. So that's basically my recommendations in a nutshell. I don't get into hormone replacement therapy because I kind of find it to be almost like too controversial, and they can have some side effects and some increased rate of maybe some cancer. So I don't get involved in the conversation of hormone replacement therapy. I kind of avoid that subject altogether.
Yeah, it's confusing. I think it's the literature and that's gone back and forth, and I think it's interesting. You mentioned all the hip fractures, and there's just I just I it seemed like every time I was in call, I was fixing some little old lady's broken hip, and I think I did one time I had 7 in one call, one 24-hour period, which is just kind of crazy to think how frequently you see that and how more common it's becoming. Do you find that? Well, I mean, I think you'd mentioned, I mean, probably there's some of these supplements may be kind of a waste of time if you're not taking care of your basic dietary needs. I think it's kind of like
Right.
you're not adding to, you're not really helping. You can't put a lipstick on a pig type of thing. You got to address the bigger issues to some degree. Where do you when you're at the hospitals, because you're going to different hospitals, are you seeing any attempts to clean up the diets in the hospitals, or all just kind of this full of junk food? I know that like Mark Cucuzella in West Virginia got his
Yeah.
hospital to clean up and get rid of all the garbage and candies and Cokes and stuff like that. But what are you seeing in the hospitals?
That's a very good question, and that's a whole other story.
Well, it looks like Carlos, I think we're just breaking up too much to hear what you're saying here. So, um, and hopefully you can hear me, Carlos. We are coming to the end of our hour here. I think that I'm going to just kind of end this one here, guys. Thank you for being patient, and thanks for listening. I think we got some value information, although some of it was harder to hear. Anyway, we'll be back tomorrow, and you guys have a great day. We'll talk to you soon now. Bye-bye.